for the mechanisms of acupuncture. So I would now hand over the talk to Ilya to give this introduction about acupuncture.
Okay, very good. Thank you, Dr. Liu. So we'll go ahead and talk about some of the basic science behind acupuncture and perhaps attempt to introduce and maybe demystify or raise some important questions about this old and in some ways new technique. So, as perhaps many of our AARP members in the audience might already know, Medicare will actually cover acupuncture for chronic pain starting soon, and specifically for back pain, not due to neoplastic or inflammatory causes. Not sure what the payments will be, but it's something that more and more patients will likely be experiencing and having questions about. So it's an especially relevant topic at the moment. So let's begin with a few definitions. Broadly speaking, acupuncture can be a term that is as inclusive as the word injection. And straight from the NIH, it's really a set of procedures that involves topographic anatomical stimulation by a variety of techniques, sometimes just even by pressure, sometimes with manual stimulation or electricity, generally though with thin, solid metallic needles. There are many schools and techniques and systems of acupuncture which seek to unify these methods. This includes classical Chinese, more modern traditional Chinese medicine or TCM practitioners. There are many Asian countries with their own traditions and methods, notably Japanese, Korean, and there are Western schools of acupuncture, all tracing their lineage back to sort of the ancient classic Chinese text, but still elaborated significantly by Western practitioners, notably in France and England, and to some extent in Germany as well. There is, of course, the modern methods of neuroanatomic acupuncture called percutaneous electrical nerve stimulation. They're PENS, very similar to TENS, transcutaneous electrical nerve stimulation. Very well described in the anesthesia literature and something that we will talk about in this presentation as well. There's, of course, trigger point use with dry needling, and there are more exotic techniques like auricular acupuncture and scalp that relies on so-called microsystems. So, briefly, clinically, the procedure is very straightforward and very safe. In reality, the most common risks are needle shock, which is well known with even venipuncture needles, but is probably of also maybe higher risk with acupuncture. Post-procedurally, there is an endorphin high, which is very common and occurs generally with new protocols or new patients. Generally, this resolves, but it can be incapacitating in some patients. There are local histamine reactions, and hematomas can occur. Rarely, but more seriously, there is a case report of a cardiac tamponade due to congenital sternal defect, and that accounts for the one single documented case of fatality due to acupuncture treatment, but this can be avoided with good technique over the sternum. Pneumothoraces are also known, but less likely with the proper solid thin needles, and generally are not of a dangerous kind. Infection has actually never been documented with sterile needles, but there are cases with reused needles. So we'll proceed to a brief history, as much as we can with the allotted time. Perhaps the most interesting ancient documented possible acupuncture use dates back to the Tyrolean Iceman discovered in the Swiss Alps, nicknamed Otzi. He is well preserved and found to have tattoos over areas of the body which are known to correspond to major acupuncture points. He is also found to have osteoarthritic changes in and around those joints, and the suggestion is that the tattoos may be of a therapeutic nature. Of course, what we think of as acupuncture has an ancient Chinese origin, and Chinese medicine was well developed even in thousands of years ago. The earliest texts that mention acupuncture is the Huangdi Neijing. Again, I apologize for the Chinese pronunciations, but the Neijing is sort of the classic, as it is known, it's the classic of the Yellow Emperor, and although its copies date back to around the 800s, the first mention of it obliquely in other texts dates back to the 200 year of this common era. And that's really where the first text establishes the full theory and practice of acupuncture as we kind of know it today, although not fully elaborated. The term traditional Chinese medicine is actually more of a modern invention on the basis of some of these classical techniques, but it's important to remember that it underwent a significant standardization and simplification under Maoist control in the 50s and 60s. So some of the classical techniques actually survived better outside of mainland China, in places like Taiwan, through the Chinese diaspora, as well as Western countries where missionaries took some of this techniques and knowledge outside of China before the revolution. In the Western world, we've had eras when acupuncture was quite popular, in fact, even with electrostimulation using Leyden jars in the 17 and early 1800s. But the latest mention that was before the 1970s and Nixon's famous visit to China was a reference by Sir William Osler recommending to treat lumbago, as Medicare now does, in his case with ordinary bonnet needles, sterilized. We'll be fine. Straight into the lumbar musculature. So, getting on to the basic science aspects, we'll talk about first the most researched and best documented application of acupuncture, which is analgesia, pain control. Very, very well developed in the anesthesiology literature and in the pain medicine literature. The clinical question of its efficacy still remains a major kind of point of contention, especially among critics of complementary and alternative medicine in general, sort of these professional skeptics that you see published and that get some press, although lately been getting a little bit out of fashion. The main thrust of the criticism really involves some of the trials on chronic pain and the very real and strong placebo effect that such an elaborate and involved procedure would have. I think that a better example of its efficacy independent of placebo are some of the trials involving surgery and acute pain. Of course, there is also other lines of evidence, such as experimental studies of acute pain in the experimental setting, and animal models, which are basically placebo-proof outside of conditioning responses. Other lines of evidence which we'll be discussing are objective changes in the pathology and biomarkers, and of course, neuroanatomical and neuroimaging correlates, which I might touch upon if we have time. So I will be going over one clinical study briefly that seems to really illustrate the advantages of this technique with regards to post-operative pain management. The literature on this is very well developed and very robust, with quite dramatic improvements in opiate use and post-op pain control, as we'll see. Some of the points that it's been shown to help with are reducing of pre-op and post-op anxiety, analgesia, including objective reductions in postoperative pain medication requirements, anywhere between 20 and 60%, depending on the studies. Improvement in autonomic stability and homeostatic regulation perioperatively, important for our anesthesia colleagues. And of course, nausea and vomiting, possibly even independent of the opiate use. There is also evidence that it reduces surgical scar, inflammation and pain, keloid formation locally, and has been shown to be effective for phantom pain in some studies. The intraoperative use of acupuncture in the setting of actual anesthesia may not be as effective, since there is quite a bit of evidence that an intact, at least most of the nervous system needs to be intact for this to work. Nevertheless, it does serve as a good adjunct for sedation techniques, conscious sedation in many studies. So I want to discuss briefly a paper that was written actually almost 20 years ago by a group in Japan and published in Anesthesia, the journal, which shows quite a range of effects which will be relevant for us here. The study involved the placement of these very small intradermal needles in a blinded fashion, double-blinded, I might add, along the sort of dermatomal and myotomal regions for upper and lower abdominal surgery. It takes advantage of a system of points on the back known as the shoe points, which are in the paraspinous musculature. The survey showed that blinding was effective. Patients didn't know whether they just got pricked or whether they had the intradermal needle placed. And the evaluators, after the fact, were also blind to whether the patients were treated or just procured and left with a fake piece of tape. This was done preoperatively, and the patients underwent their planned lower or upper GI procedure. The results, this was about 20 years ago, so the post-op pain management was done by a epidural catheter, which was placed preoperatively and before the needles too. And as we see, there is quite a significant effect for post-operative morphine consumption. The stars on days, particularly on days 2, 3, and 4 post-operatively, for both the lower and upper abdominal surgery, the stars indicate statistical significance. There is less nausea and vomiting in these patients, and interestingly enough, there is quite a bit of change in some of their catecholamine and even cortisol levels. Approximately 50 patients were in each group, so in the control and in the two upper and lower abdominal surgery groups. So small trial, but the effects are statistically significant. We see less catecholamines and less cortisol post-operatively, which may be quite beneficial. This study really is really illustrative in that most research will be similar that you'll find in the surgical literature in regards to post-op pain and opiate consumption, as well as some of the interesting neuroendocrine effects, which we'll be discussing further. So, continuing with the issue on control of pain, we see that the early studies, and by which I mean the studies from the 1970s, again, after the flurry of interest from Nixon's visit to China, was really led by two major groups. One is Professor Bruce Pomerantz at the University of Toronto and Zhisheng Han from Beijing University. Both of these groups, led by these researchers, were very much interested in the mechanisms of pain control. And so they performed some of the real hallmark studies. The earliest ones were quite basic. as we see illustrated here, they used a couple points which are considered to be traditionally the largest and most broadly effective points in the body. Heigu, which is also called large intestine 4. As an aside here, don't get caught up on these designations with an organ and a number. These are actually imposed by sort of a Western missionary kind of reinterpretation of the system, and actually doesn't show up in the traditional texts. The naming is very different for these points. Although it has stuck and it remains sort of the current international standard, this is because it is somewhat useful, but you shouldn't think that just because a point is called large intestine 4, it has really that much correlation to what we think of as the anatomical organ. The other point being that was used extensively in these studies was Zusan Li, stomach 36. Again, these are two of the classically major points with very broad systemic effects. So what was seen in these early trials was that in patients and experimental human volunteers who were exposed to acute pain, acupuncture, whether it was electrical or mechanical stimulation with needles at these points for up to an hour, created a increase in pain threshold, which reached a plateau at about 40-50 minutes and persisted for some time after. And this increase in pain threshold was actually blocked when local anesthetics were instilled into that point. So without the feeling of the needle generated by the needle, there was no change in pain threshold. There was no analgesia. The effect was predominantly segmental, but not entirely. So the hand or limb in the surrounding area was quite effectively controlled. The pain threshold was quite effectively controlled. Local and regional blocks also attenuated the effect significantly. So an intact nervous system was important. Interestingly, patients with various kinds of neurological injuries, including spinal cord injuries, had attenuation of effect, but not entirely. And we can maybe discuss why some of that happens later. So to continue, we need to review briefly the neuroanatomy of pain. This is some very basic theory. Of course, chronic pain and even acute pain is a very complex phenomenon from the periphery all the way to the cortex, and involves quite a broad range of the signaling system, including immune cells and the endocrine system. But to discuss briefly in broad strokes, we have our neuron of the dorsal root ganglion, particularly C fibers and to some extent A delta fibers, which synapse in the cord, and with two second order neurons that then proceed up to the spinothalamic tract. There are interneurons in the lamina of the cord which produce enkephalins and other opiate peptides, and these interneurons are modulated by pathways that descend from the periaqueductal gray, which goes to the nucleus raphe magnus, and that goes down and modulates these enkephalin-containing interneurons. The neurons that descend, the tracts that descend from nucleus raphe magnus are predominantly serotonergic, and that explains why serotonin modulating drugs are commonly prescribed in chronic pain to adjust this nociceptive threshold through the interneurons. The locus ceruleus is also involved, and it sends tracts that also modulate descend to the interneurons and also promote the production of enkephalins. And this is generally considered to be a noradrenergic pathway. And this is also why catecholamines are commonly used as pain modulators. Certainly when we prescribe SNRIs and things like that for chronic pain, this is what the theory of their efficacy is based on. The other thing that is important to note is that the modulation of pain isn't just due to these descending tract effects on the interneurons. There's quite a lot of information processing that occurs in the laminae of the cord, wherein A delta fibers that are myelinated interact with networks of interneurons in the lamina, including inhibitory neurons in lamina 1, 3, 4, and 5, and where some of this pain signal is reinterpreted and blocked. We see here this gate control theory illustration, where in A delta fibers, which synapse on the interneuron, also activate that, as well as activating the second order neuron for the signal. And that blocks some of the C fiber signaling. So it's a little bit of a busy slide, but this is just purely for reference to show that the research tracks by Dr. Hahn and Dr. Pomerantz were quite clear in establishing the endorphin hypothesis of acupuncture analgesia. That's what AA stands for in the slide. The evidence is quite robust, and we won't go through all of it, but I just do want to highlight a few points that are particularly convincing. The use of naloxone to block acupuncture analgesia has been proven many times in many different contexts. They have proved that both CSF and blood can be transfused into acupuncture-naive animals from animals that are receiving acupuncture and induce similar analgesic effects. There are clear changes in enkephalin synthesis in the brain and pituitary after electroacupuncture, suggesting that there are effects that are not just local to the cord, but systemic. There are areas of the brain that are that can be blocked with naloxone and that block the effect of the acupuncture, including areas in the lesions in the periaqueductal gray that abolish the effect of acupuncture analgesia, and various lines of evidence that show that this endorphinergic interneuron pathway is critical for what we think of as sort of modern surgical electroacupuncture analgesia. It's important to note that this effect is quite segmental and may not be acupoint specific, may occur just in the dermatome or myotome that is stimulated. And neither is it necessary that this is occur percutaneously, as TENS, transcutaneous electrical nerve stimulation, works almost as well in many of these trials. What's interesting, though, is that the frequency of stimulation, whether it is mechanical or electrical, seems to play a big role in determining the type of analgesia that occurs. Now, this is sort of was an elaboration of traditional techniques of needle stimulation and something that has been clinically known for a long time. But it is there is a very good tracks of evidence that low frequency stimulation tends to produce enkephalin and beta endorphin, that is opiate peptides, which primarily work on the mu and delta receptors. And as the frequency is increased, there is a release of monoamines and dynorphin, which is a kappa agonist, resulting in a different pattern of analgesia, control that is analgesia that is shorter acting, And actually, this dynorphin effect eventually results in the production of cholecystokinin, which is the major anti-opiate peptide in the spine. So there's quite a strong feedback loop, negative feedback loop with the high frequency, such that sort of the low frequency effects are sort of have a more long-term effect and have more of an effect to reorganize some of these networks which may be active in chronic pain. There is also some very good research on how to combine these effects, actually from a group by White and al. From the University of Texas Southwest, where combining high frequency and low frequency stimulation leads to the strongest analgesic effect, and where post-op morphine consumption could be slashed by over 50% by alternating high and low frequencies in a short duration. So to summarize some of these findings, we see that the release of enkephalin and dynorphin by low frequency signals blocks the ascending signal from the spinothalamic tract. There is also clear evidence that midbrain structures are involved with some of these release of monoamines and sort of the change in the way the interneurons process and the promotion of opiate peptides there. And there is also evidence that there are broader systemic analgesic effects at the pituitary hypothalamic level, where there's release of beta endorphin and adrenocorticotropic hormone from the pituitary, where there's broader analgesia. And this is primarily with the low frequency stimulation that we see it in rats. It is important to note, in the interest of time, I'll kind of go through this quickly because I want to get to the some of the more interesting trials, that there are local effects of the needle, and these may be crucial in affecting the pain as well. So C fibers are not just sensory, they are also involved in neurogenic inflammation through the production of substance P and CGRP, calcitonin gene-related peptide, big issue in migraines, as we know. The local effects of the needle are multifold. They release direct muscle spasm. They can be used to break up fibrosis and stimulate blood flow, as is done for trigger points and dry needling. They cause actually mast cell degranulation, and they cause the release of adenosine locally from fibroblasts and collagen. In fact, there is evidence that the process of acupuncture is collagen dependent, because injection of collagenase, as well as blockade with TRPV2 receptors, like agonists like capsaicin, mustard oil, things like that, irritants, tends to block the effect of acupuncture at the point. But there is quite a lot of interest in adenosine, which shows that acupuncture increases tissue adenosine concentrations, both in rats and humans. In this case, this experiment shows that a period of 30 minutes of acupuncture leads to quite significant increases in adenosine and adenosine precursors through microdialysate at the Zhu-San-Li point on the leg, the one we discussed earlier. This has been shown to be in humans and mice, although this trial was done in mice. And furthermore, the increase of adenosine, if blocked or enhanced, has a respective effect on the analgesia at that segmental level. So the use for pain is quite established in the literature. It's quite standard. It's quite overwhelming in the number of studies and trials of various kinds that have been put forth in terms of animal models, human experimental trials, and of course operative surgical clinical experience. but doesn't really answer the question of how the other claimed effects of acupuncture really work. And we really haven't discussed acupuncture as the system of acupuncture. We have discussed segmental analgesia through mechanical and electrical stimulation, which many critics argue isn't real acupuncture, it's a acupuncture-related technique. I would argue that if you're putting in needles and stimulating them, it's still a kind of acupuncture. As I mentioned before, the term is quite broad, but the whole elaborate system of meridians and special points hasn't really played a role yet. So to understand how there might be some logic to these ancient and arcane ways, we have to really dig down into the systemic effects and the nature of what are these points specifically. So to that end, we also need to start with some of the earlier studies, and these can be broken down into several lines of research. The first is the microanatomical studies conducted by the French in the 70s and 80s and earlier, which were interesting but didn't get much attention outside of the French acupuncture setting. There were numerous theories involving the fascia, special connective tissue that may play a role in making these points specific. There have been numerous analyses of nerves and trying to understand how the nervous system is involved. But perhaps the most reliable method that's been, for which we have objective evidence, are the electrical properties of these points. So we see experimental trials on the lower right, wherein several groups of healthy volunteers, 7 patients, were taken and simply mapped using an electrode at traditional points. You see on the bottom is a list of these traditional points, and you see that the bar graphs represent whether or not these points corresponded to a local area of reduced resistance. So these were absolute minima in resistance, which were mapped relative to the surrounding tissue for a few square centimeters. So as you can see, not everyone had all the points. In fact, certain points were local minima of resistance and local maxima of electrical conductance for all the subjects tested. And some points were only found on one patient. Well, how can that be? Well, it may be that certain points are, in fact, spurious, or it may be that they are an ephemeral phenomena, and this ephemeral phenomenon comes up with certain pathology. This theory will be explored in a little bit. It's important to note that the French had already established quite reliably that many acupuncture points represent areas of increased skin conductance. The histology of the underlying structure was also thoroughly investigated. The Zhusan Li stomach 36 point on the anterior tibia, as seen before, was biopsied in volunteers, mostly medical students actually, and in cadavers. And it was found that there is nothing unique about this, except that there are several interesting structures in the area. There seems to be a loose column of connective tissue in which there is what's called a neurovascular lymphatic bundle, so that there are, in fact, myelinated and unmyelinated fibers surrounding a vessel, and it can be easily stained and quite reliably found on at least some of the major quote-unquote points, reliably at the famous stomach 36 on the anterior tibia, which, by the way, overlies the deep perineal nerve. So how could it be that these points may or may not be electrically, mapped in different patients. Well, a recent study, and the one that I think most succinctly describes at least a major aspect of acupuncture and explains perhaps a major aspect of these traditional theories, was conducted by a Korean group, including with collaborators from UT Galveston, from some of our local researchers. Now, this study involved the mapping and activation of neurogenic inflammatory areas of the skin in rats subjected to a model of hypertension and induced colitis. So groups of about 18 rats in each group, including the control, had hypertension induced through immobilization or colitis induced through the injection of an irritant into the colon. Within moments, basically, they were also injected with Evans blue dye, and the neurogenic inflammatory spots were mapped. So, interestingly, when the rats were subjected to this hypertension model by immobilization, which we will see in the next slide, they had extravasation of the dye into areas of the forearm corresponding to the roughly C8T2 dermatome, which also corresponds to the sympathetic innervation of the heart. These areas of the skin remarkably correlate with known acupuncture points, which are actually relevant to cardiac function. As the name suggests, pericardium 6, pericardium 7, heart 7, and some of the other points on the hand. We see that there was a remarkable overlap between the anatomic description of the points, as I mentioned, and the extravasation of the dye. And it's only a few rats are shown, but this was done quite reliably. Now, well, what does that mean? I mean, what's the relevance of this? Well, we'll get to that in a sec. You see, in the colitic rats, the rats who had colitis induced, they also had neurogenic spots, but these were in a very different distribution, primarily in corresponding to the L2-S2 dermatome on the rat. And they also, in many cases, most cases, correlated quite remarkably with traditional points that are actually related to sort of GI function traditionally. Quite interesting. You'll have to sort of take my word for it, but it's quite remarkable that these points have traditional applications for at least related to the organ which was affected. So what? Well, if you take the hypertensive rats, which were made hypertensive by prolonged immobilization, and then you subjected the rats to acupuncture, in this case, manual acupuncture with a special machine that that stimulated the needle for about 6 seconds, once every minute for 10 minutes. So not that intensive a intervention, really. And you stimulated the neurogenic spot that appeared. You see that the systolic blood pressure normalized, well, not quite normalized, but significantly decreased in a way that was statistically significant. Now, to prove the specificity of this neurogenic inflammatory point, what they did was they selected a point that was 3 centimeters nearby, and they also even selected another anatomically correct acupuncture point, as seen in figure C, and stimulated that in the exact same way. As you see that there was no real significant change in the blood pressure. Furthermore, if the points were basically blocked with an injection of vanilloid receptor agonist like capsaicin or mustard oil, then the hypertensive effect was also blocked. And again, stars indicates statistically significant differences from the control. So a very interesting phenomenon that's specific to the point and involves the same kind of stimulation that would be used in a clinical setting. Now, the question also arose whether this effect was opiate mediated. In fact, injection of naloxone into the rostral ventrolateral medulla seemed to attenuate at least a good bit of the acupuncture effect at the neurogenic inflammatory point, but not completely, as you see as the time of the restraint goes on beyond about 80 minutes. The use of the vehicle did not have that. It basically had no effect. The rostral ventrolateral medulla is involved with some of the sympathetic regulation of cardiac tone. The morphine administered systemically also blocked some of the hypertension to begin with. So in the restrained rat, morphine effectively calmed them down and prevented the stressor of immobilization from causing hypertension acutely. Now, going to the colitis rat, they used a trinitrobenzene sulfonic acid enema to induce colitis in the rat, which lasted for days, caused massive inflammation, bloody diarrhea, loss of body weight. And as you see, acupuncture, again, manual stimulation, 10 minutes, once a day, was enough to substantially rescue the body weight of the rats. And this was not quite as effective when done at a nearby site, as you can see in figure B. There are also other objective markers besides body weight that were studied, including the amount of diarrhea that the rats produced, and as well as inflammatory markers like myeloperoxidase activity in the colon, which was quite reduced by the neurogenic spot stimulation. Furthermore, other inflammatory markers were also studied, like TNF-alpha and interleukin-1 beta, and these were significantly different between the control rats, the neurogenic inflammatory spot stimulated rats, and the rats that were stimulated at a control site. Okay, as you can see here, these are measures of some of the other markers that were tracked in these rats. Again, stars indicate significant differences. Okay. Finally, they also did biopsies of the neurogenic inflammatory spots themselves, and we see here, stains for DAPI, which is sort of a non-specific fluorescing stain for membrane integrity, and we see which is sort of a control, and then we see stains for fluorescent antibodies for CGRP. And we see quite a bit of CGRP activity at these neurogenic inflammatory spots, which is quite interesting because this overlaps with a lot of the research that's being done on migraines right now, and quite relevant. These, the extravasation of the contrast, the local inflammation at the spots, would also explain the conduction changes that would occur. And in fact, not shown here are the increase in skin conductance that occurred at those spots. So similar to what we see in traditional acupuncture points, done in studies elsewhere, these neurogenic spots were not only mechanically sensitive, but also represented local areas of skin conduction maxima. I didn't include those graphs for brevity. Finally, and I think this is sort of the icing on the cake of this study, which is so comprehensive, is that the researchers went ahead and injected sort of retrograde neuronal mapping tracers into the neurogenic inflammatory spot on the hind limb and the apex of the heart. They used fluoro gold in the heart and DIL in the DIL in the neurogenic inflammatory spot, and they found that approximately 6% of neurons in the spinal cord actually overlapped for both tracers. So there are some neurons which clearly communicate with the sort of the dermatomal area which is inflamed and the end organ which may be affected. There were actually similar studies done by other groups on the Zusan-Lee point on the anterior tibia, which was a major study point done before, and the stomach, and it using a viral vector for neurotracing, pseudorabies virus, and that showed basically amplification on higher order neurons in the area postrema, the dorsal, excuse me, the dorsal motor nucleus of the vagus, and other complexes involved in sort of parasympathetic activity. So these weren't the first trials to do such mapping, relating the somatotopic innervation along sort of the interaction between the somatotopic innervation and the visceral innervation of spinal and higher level neurons. So to summarize what the study shows, it is not a comprehensive test of the classical theory, but it does link together several features of acupuncture points, that is a therapeutic effect, the mechanical sensitivity of the point, which by the way is considered to be an important practical, clinical, and traditional way of evaluating the relevance of the point to a particular patient or treatment, the local electrical conductance, and the direct connection with an internal organ. All of these key features were demonstrated by these neurogenic inflammatory spots, which were induced in the rat. It suggests a very active role for the nervous system in terms of the way C fibers interact with both the visceral organs and their cutaneous manifestations, and lends a very elegant and well-connected explanation for many of the effects that we see with acupuncture. Now, we're coming up to the end here, so and this really is the most important, I think, and very recent paper on this matter, but there are several other effects, many other effects rather, which are quite robust and I think poorly explained completely. And so some of these other effects I'll try to summarize briefly in the next 5 minutes to leave time for questions. Well known is the effect of acupuncture on GI motility, and the Department of Surgery at Duke produced several very good practical basic science papers on this in an animal model. They used hook-shaped needles in rats and demonstrated that there is a differential effect based on the acupoint. So stomach 36, where do you know where that is? Stomach 25 is located roughly along next to the umbilicus, and bladder 21 was a control point on the back. We see here that the gastric motility, as measured after a baseline, was increased dramatically by stomach 36 stimulation, decreased by stomach 25 point stimulation, and remained unchanged with bladder 21 point stimulation. we see the same thing using the actual GI motility data here. It seems that this interaction may be explained by some of the overlap between the somatic neurons and the visceral neurons that occur in lamina 4, 5, and 7 of the intermediolateral nucleus of the spine. As I mentioned earlier, tracer studies using viral tracers suggest that there's quite a bit of overlap in these and in higher areas of the central nervous system. This effect is not limited to GI motility. The same study measured heart rate variability in these rats and in fact measured the ratio of low frequency heart rate variability and high frequency heart rate variability. The former low frequency is thought to indicate a both sympathetic and parasympathetic tone, and the high frequency aspect of heart rate variability is thought to reflect primarily parasympathetic tone, so that the ratio suggests a way of measuring the balance between high and low, between parasympathetic and sympathetic activity. As seen in this graph, the low frequency, high frequency ratio showed a primarily parasympathetic stimulus with stimulation at stomach 36 in the rat. At stomach 25, it showed a predominantly sympathetic effect, and bladder 21 was, as a control point, did not show any effect one way or the other for the duration of electroacupuncture treatment indicated by EA in that small bar. The effect was quite long-lasting, as can be seen. Again, stars indicate statistically significant differences from baseline. To wrap up, I'll skip ahead in the interest of time, but there are more clinically oriented trials which small, but suggest that there is definitely an effect on inflammatory markers in the acupuncture-treated patient. This is a live human trial which showed that performing acupuncture by an experienced acupuncturist for 30 minutes resulted in quite immediate changes in interleukin and tumor necrosis factor alpha levels. Again, I just put this on as an area of possible interest. I won't go too much into all this. It's not the only trial. There's German studies from the Anesthesia and Immunology Department of the University of Heidelberg, which showed kind of long-term effects on in asthma patients on interleukin levels and lymphocyte proliferation. As you can see, the stars indicate statistically significant differences from the control group, which in this case received a standardized acupuncture treatment that wasn't customized for asthma. So in this case, it's a very interesting trial because it actually compares not a placebo, but sort of the quote-unquote wrong treatment of acupuncture. So there are some effects which are clearly the same, and there are some effects which move in quite an opposite direction, like the in vitro lymphocyte proliferation rate. Interestingly, the asthma patients that were treated sort of per protocol had a higher lymphocyte proliferation rate than the patients who received sort of standard non-asthma acupuncture treatment, as can be seen in the upper left panel, the second from the left column. Anyway, there are other systemic effects. Melatonin secretion increases in patients who are treated for 5 weeks as measured in their urine. Their actual time in stage 3 sleep increases. Patients who are treated for insomnia using sort of a skilled acupuncture treatment. these are very interesting trials because, to my knowledge, there are very few drugs that actually increase slow wave sleep, barring maybe baclofen or phenibut, which isn't even used in the United States. This represents quite an interesting effect and quite a beneficial effect for patients who suffer from insomnia. There are other unexplained systems effects, such as the ability to reliably, and this is right in the Cochrane review. I mean, this is pretty conventional stuff in the OB literature to facilitate cephalic version in patients who are in fetuses that are breech. And this is an intervention which is purely acupuncture without any other additional movement or maneuvers done by the OB. The effect is quite remarkable and actually used in some major OB centers in Europe. There's really no explanation that I can think of based on the models that we have. So, in conclusion, what I think some of this evidence suggests is that we think about biological systems in the way they should be thought about, which is complex systems theory. We are dealing with nonlinear phenomena, which are sort of dynamic, which are complex in the sense that we have interacting effects and emergent properties that are not subject to the sort of linear mechanical interactions that we normally expect of mechanical systems. We have to think of this phenomenon as something that harnesses an emergent property of the organism, and we expect some inconsistencies, certainly maybe from the traditional models, but we also have the potential to explore something that's may open us up to entirely new ways of treating the patient in a way that's safe, effective, and harnesses the natural sort of homeostatic principles which we spend so much time studying and thinking about, but which we have few tools to effectively access. So this might be a tool for that kind of homeostatic re-regulation. And as neurologists, we are well positioned to take advantage of it if we don't leave it up to our anesthesia and pain colleagues exclusively. So that is all. I thank you for your time. Hopefully I haven't put you to sleep like I do my newborn. Any questions at this point?
Well, excellent talk, Ilya. And I learned a lot. This is indeed just a very complex topic that you put it together, in a very comprehensive way. I think acupuncture, the mechanism is so complex. And if it's just one thing, would I like to mention is for hot flashes, for breast cancer patients who are undergoing hormonal treatment. And there was a very elegant comparison of acupuncture treatment, and it's separated in different treatment, depends on the patient's, I would say, you would say diagnosis based on traditional Chinese medicine. If they have the so-called yang deficiency or yin deficiency, where they have this heat accumulation, they would use different acupuncture points. The thing about the treatment is that if you stop the treatment, let's say also stop some of the antidepressant for hot flashes treatment, the acupuncture effect lasts more than 6 months, even after the acupuncture treatment stops. But the antidepressant will stop almost immediately. After a week or so, the patient's hot flashes come back. That's definitely the effect that's beyond hormonal. It's not hormonal because those people are on the anti-hormonal treatment. So there's a lot of mechanism we truly don't understand. It's not purely neurological, or you talk about local. What exactly caused those people not to have hot flashes after the acupuncture treatment, we still do not know. And
Mm-hmm.
also
Yeah.
for the stomach 36, you notice it's being used a lot for GI problems. But when in reality, in practice, it's used both ways. It's, let's say, both for stomach pain, for constipation, for diarrhea. So why would have a, sort of bi-directional regulation? We don't understand that, completely.
Yeah, exactly. This is a homeostatic regulating effect, and I think the only way to really untangle some of these is to get a grip on these sort of complex systems theory and the way that systems can be sort of pushed in one direction or the other towards or out of equilibrium, rather than thinking of things mechanistically like we're used to. I think, yeah, that's a clear. There are so many clinical examples that we need to explain.
Yeah.
Ilya, this is Erica Green. Thank you for providing a great talk on a subject for which I knew very little about, especially any basic science or study. So thank you for that, and thank you to your mentor. And I stepped away, so this might have been asked and answered. Do we have any evidence on, or do you know about recurrent or ongoing acupuncture and permanent or long-term changes in terms of these neurochemical responses, supraspinal modification? In other words, is there a cumulative and long-lasting, if not permanent, change with ongoing acupuncture?
That's a very good point. Certainly, we see shorter term trials, and of course, as Dr. Liu had mentioned, the long lasting effects on things like hot flashes. There's is something that's very difficult to study in humans, but we do see a lot of trials, a lot of studies on the sort of the neurological and histopathological changes in rats from recurrent acupuncture treatments, like resprouting of GI ganglion networks that are damaged by diabetes. We see that in the animal model. So there are definitely effects on neural networks in the GI tract that are actually very well studied. So I did encounter quite a lot of papers on that specifically. Regarding the brain, I don't recall, but I'm sure that there are groups working on it. It would make sense that there are some network effects in the long term. It's traditionally, clinically, what's done is patients are often treated for acute problems first using treatments that are every day even, or every other day, or a short, as close together as possible, and then it's spaced out as the sort of acute process dissipates, and patients can come in as infrequently as once every 6 months or once a year for so-called tune-up treatments. At least that's what many practitioners do in the clinical setting. So there's clearly some effect that can be thought of to occur on the network level.
Yeah, I don't know any trial that followed a patient, for I would say lifetime to see if some of the effect that last that long. And I agree with Ilya as far as the clinical practice. Patients, let's say, being treated for neuropathy, once they get better, they would have this periodic drop in if they see a hint of the, let's say, chemotherapy-induced neuropathy feel coming back, and they would just go back and get a couple of treatment, and then probably won't come back until 6 months or even a year later. So, but I have not seen a very systematic report of those chronic conditions, how often patient required acupuncture treatment, or is there a point they stop and then they don't require any more treatment? I don't think I've seen any of those kind of reports so far.